Hi, my name is Kayla, and this is my presentation on Graves' disease, hyperthyroidism. This is a typical patient presentation for a patient with Graves' disease. A 32-year-old female presents to her primary care physician with complaints of having lost 15 pounds in the last 2 months. Her hair has gotten increasingly thin, and she's noticing that her heart is racing, even without any strenuous activity. She also has complaints of feeling warm regardless of where she is, and her palms have been sweaty quite frequently. She also presented with signs of exophthalmos. It was also noted that the women from her mother's side of the family have a history of presenting these signs and symptoms too. Exophthalmos, which is also known as bulging eyes, is often seen in Graves' disease. It is when the eye is bulging to the point where it moves out of both sockets. It can move out of one socket, but with Graves, it is usually bilateral and moves out of both. So this is the etiology. It is a form of hyperthyroidism, and it's basically just an overactive thyroid gland. It is an autoimmune disease, and it's due to a malfunction in the body's immune system. The causes of this malfunction are unknown, but there are genetic factors interacting with environmental factors, and they're known to play an important role in the pathogenesis. Here is the background. It is also known as Basedow's disease. It makes up about 60 to 80% of cases of hyperthyroidism, so it's the most common form of hyperthyroidism. It has a prevalence of about 2% for women and about 0.2% for men in the United States. So as you can see, women tend to dominate this disease more than men do. There are 30 cases per 100,000 people per year in the United States. So we have the origin of Graves' disease and Basedow's disease. On the left, we have Robert Graves, who was an Irish physician who discovered the disease in 1853. Originally, he discovered it as exophthalmic goiter, but then later the name became Graves' disease. On the right, we have Carl von Basedow, who was a German physician who published research on the disease in 1840. He basically discussed how the symptoms developed in Graves. Listed are the risk factors. The first one is female gender, and you can see the star next to it that indicates that it is a common risk factor. The reason why women are more prone to this disease is unknown. Next, we have medications. There are types of medications that increase the risk for Graves, including medications that consist of iodine, and iodine can be detrimental to the thyroid because if the thyroid takes in high amounts of iodine, it can cause the thyroid gland to be overactive and produce excess amounts of thyroid hormone. There's medications such as amiodarone, which is a medication used to treat heart diseases, but it can actually overstimulate or damage the thyroid, and it also contains iodine. There's also antineoplastic agents, which can cause thyroid dysfunction. Next, we have age. Any time before the 40 years of age will increase your risk. We have postpartum period, smoking, which will increase your risk for exophthalmos, associated conditions, which are on the next slide, stressful life events, personal family history. So this disease actually has a very strong genetic predisposition, and we also have pregnancy. These are conditions that are associated with Graves' disease. We have type 1 diabetes mellitus, mitral valve prolapse, vitiligo, which is a skin disease that results in the loss of skin color. The loss of skin color shows up in patches on the skin and is actually lighter than the rest of your skin, and these patches tend to get bigger with time. We also have alopecia, which is a hair loss condition, which is when the hair comes out in small patches. It can be on the head, it can be on your eyebrows. We also have other autoimmune disorders, such as myasthenia gravis and celiac disease. This is the pathophysiology of Graves. It is an autoimmune disease. As said in the beginning, there is an antibody that is produced that mimics thyroid-stimulating hormone. The antibody will then stimulate the thyroid to produce thyroxine. It does so by, again, mimicking or acting in a similar way to thyroid-stimulating hormone. It results from a form of type 2 hypersensitivity. Type 2 hypersensitivity is generally a reaction to a specific cell or tissue. In this case, there is stimulation of the thyroid by autoantibodies directed against the thyroid-stimulating hormone receptor. Looking over to the right, you can see this picture. The thyroid gland is located at the base of the neck, just below the Adam's apple. So here's the pathophysiology of thyroxine explained. So in Graves' disease, you have increased amounts of thyroxine being produced, and keep in mind in the previous slide, we discussed how there's an antibody that stimulates the thyroid to produce thyroxine, and thyroxine regulates the body's metabolism, heart and digestive functions, muscle control, brain development, and bone maintenance. It also alters your feedback mechanisms. So the thyroid is generally regulated by a negative feedback loop, and with Graves, the negative feedback loop is inhibited due to the large amount of thyroxine being produced. So this is just another better explanation of the pathophysiology of Graves. So an immunoglobulin G antibody is produced in Graves' disease, and referring back to 2 slides before, this is the same antibody that is produced that mimics thyroid-stimulating hormone, and it also stimulates the thyroid to produce thyroxine. So the immunoglobulin G antibody will then bind to the receptor and stimulate the thyroid as TSH would. This also causes those symptoms of hair thinning, the unexplained weight loss, the constantly feeling warm, the palpitations, the exophthalmos, all of those symptoms are due to the overstimulation of the thyroid. So here are the symptoms of hyperthyroidism. There's hair loss, sweaty palms, heat sensitivity, weight loss despite normal eating habits, enlargement of thyroid gland, also known as goiter, irregularities in menstrual cycles, anxiety/irritability, bulging eyes, also known as exophthalmos, and noticing the star on the right. This indicates a distinguishing clinical manifestation of the disease and will be described in the next few slides. You have fatigue, thick red skin, also known as dermopathy, which will also be described in the next few slides, rapid irregular heartbeat or palpitations, and sleep disturbance. So here are the symptoms explained from my patient presentation. So the first one, you had that 32-year-old female who presented with having lost 15 pounds in the last 2 months, so unintentional weight loss. She's also noticing that her heart is racing even without any strenuous activity. Thyroxine is known to increase your body's metabolic rate, which explains the patient having lost 15 pounds, and too much thyroxine produced equals, like I said, that unintentional weight loss, and it also can cause a rapid irregular heartbeat. A clinical manifestation of Graves is exophthalmos. It is when a patient's eyelids are bulging and retracting, as you can see in the picture on the left. Patients with exophthalmos can also present with redness, as you can see on the right. Exophthalmos can be unilateral or bilateral, but in Graves it is specifically bilateral, and it is caused by elevated levels of thyroid hormone, also known as thyrotoxicosis. This is another clinical manifestation, which is Graves' dermopathy, also known as pretibial myxedema. This is when a patient will present with thick red skin. Pretibial myxedema is used to describe localized lesions of the skin, as you can see on the right, those little red patches. These lesions are resulting from the deposition of hyaluronic acid, which is a component of Graves. So on the left, you can see that this patient's hands are very thick and they're very red. And on the right, you can see how the legs are almost puffy, and you can see all those kind of red patches on the picture to the very far right. So here are a couple ways to diagnose Graves' disease. The first is blood tests. So blood work can actually determine levels of thyroid-stimulating hormone, and you are expected to find low levels of TSH, because with these low levels of TSH, it is an indicator that the thyroid is making too much of the thyroid hormone. So the thyroid is monitored by the pituitary gland, so it'll monitor our thyroid levels, and when the pituitary gland detects an excessive amount of thyroid hormone in the blood, it stops the production of TSH, thus leading to the low levels of TSH. Radioactive iodine uptake will be described in the next slide. And lastly, you have an ultrasound. So an ultrasound will examine the thyroid gland and check to see if it's enlarged, because an enlarged thyroid gland is a huge indicator of hyperthyroidism. So the radioactive iodine uptake is a way to diagnose Graves. So starting off, the thyroid gland needs iodine to make hormones, and iodine is something that is found in a variety of foods, so it can be incorporated into your diet. So the patient will ingest radioactive iodine in a pill or liquid form, and that will measure the rate at which the thyroid gland is taking in the radioactive iodine. So if the thyroid is taking in too much iodine, that means that there's too much thyroid hormone being produced. So looking over to the right, you can see those two very clear differences. So on the left, you have A, which is the normal thyroid gland that takes in normal amounts of iodine, and then to the right, B. This is Graves' disease. This is a thyroid gland that takes in excessive amounts of iodine. So we have the treatment of hyperthyroidism, and the goal of treatment is to stop overproduction of the thyroid hormone. So the first is radioactive iodine therapy, in which a patient will ingest radioactive iodine. That radiation will then destroy those overactive thyroid cells, and it will shrink the thyroid gland. We also have anti-thyroid medications, which, as simple as it is, stops the overproduction of the thyroid hormone. Then we also have beta blockers, which will be listed out here. These block the effect of the thyroid hormone on the body, but it does not inhibit the actual production, just the effects. We also have surgery to remove the thyroid gland, but a patient will have to take supplemental thyroid hormones for life, because when the thyroid gland is removed, the body loses its ability to secrete the two main hormones made in the thyroid, thyroxine and triiodothyronine. And the body also loses its ability to maintain the functions of the thyroid, such as regulating metabolism. With these supplemental thyroid hormones, the body will be able to keep up with those functions. And here is just a list of my references, and if you have any questions, you can always send me an email or anything like that. But thank you so much for listening.